then you may have to repeat that direct Coombs a couple of times before it actually captures the antibody on the red blood cell together and you end up with a positive result. Welcome to Tala Talks NICU. Today we are going over part 4 and the final part of the series on hyperbilirubinemia. So we've already talked about the whole bilirubin pathway of metabolism, we've talked about hemolytic versus non-hemolytic, we've talked about immune hemolysis. Today we're going to talk about the diagnosis and management of jaundice, or diagnosis and management of hyperbilirubinemia. So let's imagine that you're taking care of a baby in the newborn nursery and baby looks a little bit yellow and you get a bilirubin level and the bilirubin is like 18. What are the different steps that you have to go through to decide whether you need to treat this baby or not? So again, remember the first lecture, the thing that we are most concerned about is whether this bilirubin is going to reach the level that we really worry about kernicterus. So what are the chances of this bilirubin getting to like the mid-20s and staying there, or even the early 20s and staying there for a long period of time that could result in brain damage? So logically, you would be a lot more worried about such a high number if we were like hour 8 of life, if the baby were only several hours old, versus if the baby were like a week old, and this could be like the tail end of the physiologic jaundice and then it's coming back down again. If the bilirubin is already 18 within a few hours of life, then that is a very concerning level. In fact, there are Butani curves, after Dr. Butani, who established kind of a nomogram for just how concerned we should be about a bilirubin level causing kernicterus. So on the x-axis, it's basically hours of life. And on the y-axis, we have the total bilirubin level. So again, I just want to emphasize that this is the total bilirubin level that it wants you to plot in. And why is that when we know that it's really only the indirect bilirubin that crosses the blood-brain barrier? If you remember from lecture 1, it's because having a slightly higher total bilirubin will displace that indirect bilirubin from the albumin, and so you'll end up with more free indirect bilirubin in the red blood cells that have the ability to cross the blood-brain barrier. So these curves look something like that. Obviously, as the hours go along, we can accept a higher level of the bilirubin. Whereas if you had like a bilirubin of, and I'm not putting in the numbers here, but if you had a bilirubin of 12 at like 8 hours of life, that is extremely concerning. The other thing that's on these curves is that they are kind of put in risk zones. So depending on where you can figure out how old the baby is and then plot exactly how high the bilirubin is and decide the risk of this baby developing into a very severe hyperbilirubinemia. So the first thing you do is you figure out just how terrified you should be about that bilirubin. If you've been working in the NICU for some time, then, or the nursery for some time, then you'll have a pretty good idea. If you have a level of 18 and the baby's 10 hours old, you're going to be pretty panicked without actually having to plot it. But just so that you have kind of a general idea of like what is acceptable for that hour age of life. In my mind, I'm always kind of like, if it's above 10 in the first 24 hours of life, then I need to be concerned and I'm probably going to be doing something else about it. So after you kind of decide, right, just how high is that bilirubin, how do I have to do any further investigation? So you decide that the bilirubin is high and that the baby probably needs some sort of intervention, whatever that may be, and we'll talk about it in a second. The next thing that you have to figure out is this baby under high risk or not under high risk? And again, everything goes back to kernicterus. Is this baby under high risk of developing kernicterus or not? So if it's hemolytic, which means, as we've talked about, the red blood cells are breaking down. So the chance of this continuing to rise, the bilirubin getting higher and higher because there's continual hemolysis of the red blood cells, is much higher. So a hemolytic hyperbilirubinemia is much more scary when those numbers are borderline than a non-hemolytic hyperbilirubinemia. So that's one of the things we have to consider. The second thing that we have to consider is how strong is the blood-brain barrier and how much free indirect bilirubin do we have. So the things that could increase the indirect bilirubin that's free in the blood is a very low albumin level. So if this is a really sick baby who's very malnourished and has kind of a borderline bilirubin, I would be a lot more concerned because that bilirubin is way more likely to go into the blood. Other things we need to consider is what is the strength of that blood-brain barrier. If it's a premature baby, they've got a much weaker blood-brain barrier than like a term baby. So again, we're a lot more concerned about a threshold bilirubin level. If the baby is septic and that whole blood-brain barrier is leaky or just not as tough as it should be because all the cytokines and everything are going around the body, again, we'd worry a lot more about that level of bilirubin. So practically, make sure the baby isn't preemie and isn't septic, and there aren't any other reasons why the baby should have like a horrible blood-brain barrier. But then the next big thing that you have to figure out is this hemolytic or is it not hemolytic? So what's the first thing that you're going to look at? What is the mother's blood type? And again, we talked about this earlier. If the mother's blood type is O or the mother's blood type is negative, then those are the two scenarios that you're a lot more concerned about an immune hemolysis. So it could be O, positive or negative, or it could be A, AB, B, or O negative. All of those would be concerning because if you go back and look at the previous videos, those are the two mother's blood types that can produce antibodies that can cross the placenta and cause hemolysis. So the next thing that you need to check, so if the mother is A or AB or AB positive, then you can move on and you can be a little less concerned about this being an immune hemolytic process. There are some other weird case scenarios, I'm not going to go into those for now. But for the time being, if you see an O mommy or a negative mommy, you need to take it a step further. And what is the step further that you take? You look at the baby's blood type. So, if the baby has a different blood type from either the O or the negative, then that's when you have to be worried. Because remember, the mother's going to be able to make antibodies and attack antigens if they are there. If the baby is also an O, then there aren't going to be any antigens on the baby's blood type for the mommy to attack. If the baby is also negative, same thing. Even if she does have Rh positive antibodies to cross, they've got nothing to attach to on the membrane of the red blood cell of the baby, so it can't actually break down. So we would be worried about the baby. If it's O, we would be worried about an A or an B or an AB, because she would make antibodies against all of those. And if the mother is negative, then we would worry if the baby was positive. There is another test that we do, and we do it really in all nurseries across the country, and that is something called the direct Coombs. The direct Coombs is testing, it's a test done on the baby's blood, and it's testing whether the baby's red blood cell, so for example, let's say that the baby is A positive, so that's the little A antigen on the red blood cell. So say the mommy was O, and she does actually have A antibodies. What the direct Coombs is testing is for the presence of one of these units. So the direct Coombs will be positive if there is a mother's antibody attached to the baby's red blood cell. So that's a very important point. It is testing for the presence of that. So you can see a slight caveat here. If the mommy has so many antibodies and like just destroyed every red blood cell, then you could have a really bad immune hemolytic process going on, but you might end up with a false negative. In fact, direct Coombs can be negative falsely about a third of the time. So if you do have a situation where, for example, the mummy is O, the baby is A, and the bilirubin is just crazy, it just keeps going up and up and up, and you're absolutely convinced that this is the immune hemolysis, then you may have to repeat that direct Coombs a couple of times before it actually captures the antibody on the red blood cell together and you end up with a positive result. So those are kind of the three things that you look at when you're trying to figure out whether this is a hemolytic process. Is the mother's blood type a setup? Is the baby's blood type in conjunction with the mother's a setup? And is the baby's direct Coombs positive? Okay, so say you have that baby, and like we said already, a baby who's only a few hours old, term baby in the newborn nursery, that suddenly has a bilirubin of like 18 at 10 hours of life or whatever. You look at the mummy and the baby's blood type, you look at the Coombs, and none of it is consistent with like an immune process. So you have, for example, mummy could be O positive, baby's O positive, and direct Coombs is negative. In that situation, there's no setup for it to be hemolysis. But that bilirubin is so high that you're convinced that there is an that there is a hemolytic process going on. For a bilirubin to get that high, you would kind of think, well, there must be a big breakdown in red blood cells. So how can you figure out if there is a lot of hemolysis going on that isn't necessarily related to an immune process? Well, obviously, if the red blood cells are breaking down rapidly, then that baby would become anemic pretty quickly, right? So you break down enough red blood cells, your hematocrit's going to fall down. That would take serial blood checks. So every time you check the bilirubin, maybe the hematocrit's falling by another 3-4 points. The other number that we can check, which is super helpful, is the reticulocyte count. So the reticulocyte count is checking to see how many immature red blood cells are in the circulation. And the reticulocyte count goes up when the bone marrow very appropriately realizes that the baby is becoming anemic and needs to ramp up its formation of red blood cells. So retics are basically immature red blood cells. If you see a high reticulocyte count, it implies that either the blood is being destroyed rapidly or the baby is losing blood from somewhere and the bone marrow is doing everything it can to kick it out. So if you do have a hemolytic process, which again means that the red blood cells are being broken down at a faster rate, you would expect a high reticulocyte count. So let's go back to that baby. We have a bilirubin of 18 at 10 hours of life. The baby is not an immune hemolytic setup, but it all feels a bit odd to you. So you send a reticulocyte count and it comes back and it's 18. Really anything above kind of 4 or 5 is pretty elevated. So it comes back as 18. This really sounds like it is a hemolytic process, even if it's not immune. And if you go back and look at the previous videos, then you're kind of going in the direction of the non-immune hemolysis, so things like G6PD and spherocytosis. So the last thing that I'll say about kind of going through the differential is that first of all, you have to make sure it's not immune hemolysis, then be very certain it's not hemolysis. And if you feel pretty good that it's neither of those, then you can kind of start going down the non-hemolytic pathway. So you're more likely to say, okay, well, this is just breastfeeding jaundice, or the baby has a huge cephalohematoma or was very bruised, so obviously we're going to expect high bilirubin for a little bit of time. It is important to figure out if it is immune hemolysis though, because that could change the way that you treat the baby. Right, now let's start going through the actual management and the treatment. So the first thing I want to say about this is that for RH disease, or really not RH disease, RH incompatibility, or any time a mummy is RH negative, so whether she's O negative or AB negative, the management of all of this starts before the baby was born. So during pregnancy, at 28 weeks, as well as at the time of delivery, the OBs will administer a RhoGAM shot to the mothers to try to kind of capture all those antibodies that the mummy's made so that they won't go through to the placenta and cause hemolysis and hyperbilirubinemia. So RhoGAM has actually completely changed all of neonatology in hyperbilirubinemia, and it's greatly reduced the risk of having the really severe hyperbilirubinemia, greatly decreased the number of double volume exchange transfusions that are needed. So really, for Rh negative mummies, that management starts before the baby is born. So now let's talk about after the baby is born, you've got a hyperbilirubinemia. So the first thing, and probably the most common thing that we see, is kind of a breastfeeding jaundice, or a baby that's a little bit dehydrated. Maybe genetically their enzymes are a bit slower, so their bilirubin gets a little bit higher. Baby's breastfeeding, maybe urinated once, maybe has pooped once, but not for several hours or not for a day or so, and the bilirubin is creeping up. So in mild cases, you would want to make sure that the baby is staying well hydrated. So you would start with kind of the hydration level, whether that is encouraging the mother to pump even between feeds and get more breast milk out, whether it is adding formula to the breast milk, which obviously we don't love doing unless we have to do, or even if we feel like the baby's really dehydrated, like the baby's down 14-15% from birth weight and is now so dehydrated that is not interested in eating anymore, then at that point we would have to put in an IV and administer IV fluids. So that just kind of helps not only the level of the bilirubin go down in the blood, but it also helps the baby's whole enterohepatic circulation to kind of rev up and the baby to start pooping out more and to kind of increase the enzymes working in the liver. So the hydration status is very important here. The second thing is phototherapy. So I know that you all know about this. So phototherapy is when it was found actually by a nurse who kind of had babies in diapers that were glowing yellow. This was in Scotland, and she put them closer to the windows. And when she took the babies away, she saw that the yellow staining was still present under the diapers, but the rest of the bodies had kind of gone back to their pinkish color. And what was so genius was that she figured out that the light in some way was getting rid of that bilirubin. And so finally they kind of figured it out that it's light in the blue wavelength that causes a photoisomerism in the bilirubin that takes this fat-soluble indirect bilirubin and makes it water-soluble, so the babies can then pee it out as well as poop it out much easier. So phototherapy is kind of what we use to really get that bilirubin down when we have to, when hydration isn't quite enough. So it is done for several hours or a day at a time, and we kind of follow serial bilirubins while a baby is under that. Just trying to get them lower down on that Butani curve so that they're now in kind of a low risk area rather than a high risk area. We always put little glasses, little shades on babies when we put them under phototherapy. This is just so that they don't get annoyed. The blue light is part of the regular light spectrum. It's not UV light. It's nothing that's going to actually damage the baby's eyeballs. It's just so that it doesn't get irritated. So, parents do ask this a lot. Increased risk of eye damage, of blindness, of ROP, none of it. We only put the shades on so the baby don't get irritated. And now, number 3 is only in immune hemolysis. And that is the use of IVIG. So intravenous immune globulin. So if the mummy is O, like we said, O or negative, and the baby is direct Coombs positive, and the mother's antibodies have gone through the placenta and now breaking down the red blood cells, we can give the babies IVIG, and those IVIGs, those globulins, will grab onto those antibodies that the mother has kind of given through the placenta, and so it will stop them from actually attaching to the red blood cells and destroying the red blood cells. So IVIG has been shown to be extremely helpful in ABO incompatibility as well as in RH incompatibility. So if you have an immune hemolytic setup, so you've got a mommy that's O, a baby that's B, your direct Coombs is positive, your reticulocyte count is elevated because the blood is breaking down, and your bilirubin is high, then that would be a logical thing to do. You give IVIG, and we normally give about half a gram over several hours, and that can be repeated, but normally just one dose of IVIG is normally enough for these babies. And then if you've done the phototherapy, you've been feeding the baby's pooping, and you are, giving adequate IV hydration, and still that bilirubin is really, really high, or the baby presents to you and you don't even want to risk spending any more time trying to get that bilirubin down, then ultimately you've got to do whatever it takes to get that bilirubin out of the blood and away from the brain. And then that's when we go to the double volume exchange transfusion. I am not going to talk about this a lot, only that what you're basically doing is pretty much replacing the blood with blood without bilirubin in it. I did an entire video on this, so go look at that video. Again, we do this extremely rarely. We've done maybe a handful in kind of the last 15, 16 years. How many of you done, Justin? Zero. Justin has done 0, and he's been working in the NICU for like 11 years. So extremely rare now, mostly because of RhoGAM being given to mummies. So that's kind of like the order of how we treat babies. Okay, and that finishes the whole series on jaundice. I know that there are a lot of caveats that we didn't cover, but if you do have questions about it, then please write to us or comment below. And in the meantime, remember to like and subscribe and go answer the multiple choice questions. Thank you.